Hello, and welcome to the first installment of the Health Storytelling Author Q&A series for this semester, Spring 2025. I'm Maryn McKenna. I'm a journalist and author and senior fellow in the Center for the Study of Human Health at Emory University. I'm the curator of this series, which makes me your host as we undertake our latest set of author conversations. In a moment, I'll introduce you to our guest, Caitlin Rivers, PhD, Associate Professor at the Johns Hopkins Bloomberg School of Public Health, and her timely and important new book, Crisis Averted, The Hidden Science of Fighting Outbreaks. But first, let me tell you about the semester series. At least once per month during the academic year, we invite writers whose journalistic or academic books examine health, the science and history of health, and health's intersection with society. These series of conversations is sponsored by the Emory Center for the Study of Human Health, along with an array of fantastic co-sponsors. This spring, the co-sponsors are the Georgia Center for the Book, a local affiliate of the Library of Congress that stages very frequent public conversations with authors, illustrators, poets, and others to bring the news of new books to the public. Then, Emory's Center for Public Scholarship and Engagement, which creates opportunities for faculty, staff, and students to share ideas with local and global audiences. And also the center's new Ideas Festival Emory, which launched last September on Emory's Oxford campus and will return next October with an amazing lineup of speakers. And for one of our events this spring, the amazing Atlanta Science Festival, which sponsors 2 whole weeks of events to bring science to the public. I'll tell you more about their involvement in a minute. So let me tell you who'll be appearing in this series this spring. The series is live streamed on YouTube, LinkedIn, Facebook, and Instagram, and archived on YouTube. The authors appearing this semester are tonight, Dr. Caitlin Rivers with Crisis Averted, The Hidden Science of Fighting Outbreaks from Viking. On February 26th, Adam Ratner, MD, with Booster Shots, The Urgent Lessons of Measles and the Uncertain Future of Children's Health from Avery. On March 19th, Carl Zimmer, award-winning science writer and New York Times columnist, and his brand new book, Airborne, The Hidden History of the Life We Breathe from Dutton. Carl's event is a co-production with the Atlanta Science Festival, and we are extremely thrilled to partner with them on that. And finally, on April 16th, our last event of the semester, Emory professor Jaap de Rode with Doctors by Nature, How Ants, Apes, and Other Animals Heal Themselves from Princeton University Press. One final note, this is a live event. You can interact with us, and we encourage you to do that. If you want to ask a question, please comment on any of the platforms where you are watching us, and our producer, Stefan Kaplan of Spin It Social, will make sure we see what you said. Do note that I'll turn to your questions in the second half of this 60-minute live stream, but you can put your questions in at any time. So now let's turn to our book and guest. Dr. Caitlin Rivers is an epidemiologist who specializes in outbreak science and an associate professor at the Johns Hopkins Bloomberg School of Public Health. She was a founding member of the Center for Forecasting and Outbreak Analytics at the Centers for Disease Control and Prevention. That launched in 2022, but she had been an advocate for years before that for the need for such a center to exist. And in our conversation, we'll talk some more about that. During the COVID pandemic, Dr. Rivers was an influential participant in setting government policy responses to the outbreak. She's also a prominent science communicator. She's written pieces and done interviews for media such as USA Today, the Wall Street Journal, the New York Times, the Washington Post, Foreign Affairs, Vox, NPR, and I should probably add, also speaking to me when I was leading COVID coverage at Wired magazine. She's also a Substack author. Her newsletter there is called Force of infection. Caitlin, welcome to this series.
Thank you so much, Maryn. It's great to be with you and everyone listening in today.
So congratulations on the book. I have been wanting to talk to you about it since it came out in October, I think. The past 10 days in the United States have made its content more timely than ever. And we'll talk about that over the course of this hour, but not right away. So let's get to the book content. I always want to ask people to start with, for the sake of the audience, I recited your bio, but beyond that, who are you? And tell us a bit about what it is, the work that you do, both at Hopkins and at the CDC.
Sure. I am an infectious disease epidemiologist, which means I study outbreaks, epidemics, and pandemics. And in fact, I've always focused on those large end events like epidemics and pandemics. And so you can imagine the pandemic, the COVID-19 pandemic, was a really busy and grueling time for me, but also a place where I feel proud that I was able to contribute my expertise. I am an associate professor at Johns Hopkins. I've been there for about 8 years. And at Johns Hopkins, I lead a group called the Center for Outbreak Response Innovation, where we work on improving outbreak responses to make them more efficient and more effective. We're part of the Center for Health Security, which is a group of amazing experts who specialize in epidemics and pandemics, but from all sorts of different angles. So I'm an epidemiologist, but we also have lawyers, we have people who specialize in risk communication, we have people who specialize in anthropology, really every angle. And it's in that home where I've been focused for about 8 years now. Now, I did have an amazing opportunity in 2021 and 2022 to do what's called actually, I'm not going to say what it's called because IPA, whatever IPA stands for. But basically, I was allowed, Johns Hopkins loaned me to the CDC to help to found the Center for Forecasting and Outbreak Analytics. I was able to retain my position at Hopkins, but spend a year at CDC doing the amazing work of founding CFA. Just a quick word about CFA. It is the newest center at CDC, and it's really focused on producing the kinds of analytics, modeling, and forecasting that decision makers need to respond to outbreaks, epidemics, and pandemics. And so that center is now in its 4th year and absolutely thriving. And I'm so proud of the impact it's having and the way that I was able to contribute in its early days.
So I want to ask some more a little later in this hour about exactly what the center does and what your part of that was. But really what I want to start with, since we're here to talk about the book, is how did this book come about? As I said in my bio, you were very prominent during COVID as a science communicator talking about outbreak response, but I suspect that this approach that you have in the book to talking about outbreaks and public health might predate that.
Yeah, I've always really appreciated the ability of stories to help us to understand kind of the inside of universes or worlds that are otherwise really hard to step into. So I'm a big fan of Atul Gawande, just to give you a sense. Learned a lot from his storytelling approach to how surgeons learn to do their incredible work. What do you do when you are first stepping into the role of a surgeon and having none of the skills, but all of the responsibility of caring for people? I really appreciated his narrative storytelling approach to that kind of behind the scenes work. I really wanted to do something like that for public health to help people to understand that public health is something that is invisible to so many of us because its work is to make things not happen. It's a really difficult story to tell. It's difficult to make the case that nothing happening is something special. And that's why I relied so heavily on stories about how outbreaks unfolded and how the heroes of those tales of outbreak responses, of moments of crisis, were really kind of elevated and helped me to reveal just how much work goes into helping things not happen. I was able to really have the opportunity to write a book because I did spend a lot of time during the pandemic communicating to the public, translating the latest scientific developments, trying to give people the strength and insight to help them go on through a very difficult time. And I think that sort of skill and engagement is what allowed me to step into the writing or the literary world in a way that not all academics prefer that activity.
So I'm glad that you mentioned stories because it's important, I think, to acknowledge that you start the book with a very personal and poignant story, which is a story of your own about a very difficult pregnancy. Can you walk us through that and make the connection for us between wanting to tell that story of a single person's experience, or three people's experience if you count your twins, um, and how you relate that to the population-wide experience that defines public health?
Yeah, absolutely. I am the proud mom of three girls, and two of them are identical twins. And my identical twin pregnancy was absolutely horrible. It was devastating. Because they are identical, they shared a placenta. That is one of the defining features of identical twins. And for many identical twin pregnancies, that sharing works fine. But we developed a complication called twin to twin transfusion syndrome. It is unique to identical twin pregnancies, and it means that one twin is donating, that's the word they use, believe it or not, donating blood to the other twin through the placenta. And so one twin becomes anemic and the other one becomes deluged through excess blood. Now, the only treatment for this condition, which is otherwise, I'm sorry to say, basically universally fatal, is a surgical procedure to separate the blood supply through the placenta. So me and my twins during my 16th week of pregnancy underwent a surgery to separate the placenta. We actually had a relapse a couple weeks later and had a second surgery, a second fetal surgery, and basically limped along through the pregnancy like that with complication after complication, all of which were potentially devastating or even fatal to the three of us until the 31st week of pregnancy when I delivered, of course, preterm. It was further along in the pregnancy than I actually thought we would make it because we had survived so many interventions. But nonetheless, because they were 9 weeks early, they spent a long time in the NICU. And so this entire saga, which was incredibly harrowing, lasted about 8 months. And I feel very fortunate that we made it home, that we all pulled through, and that I'm able to enjoy my beautiful girls today. They're now 6. But I really wanted to bring that story to the readers. And indeed, I opened the book with this story because it's a window into what it looks like when we lose our health. Public health is really about creating the conditions for good health to endure, for us to enjoy it. And I think in order to really appreciate what that means, we have to look at the other side and we have to really examine what it means to be in poor health and just how terrifying it is. And that is a shared experience across all humans. All of us are born, we get sick, we eventually die. And that's really the interface, the work of the medical system. And I just wanted to remind people of those experiences so that they could better appreciate what it means to be in good health, which of course is the work of public health.
There's so many strands in that story. I'm so glad all three of you are well.
Yeah.
that resonate throughout the book. The benefits of technology, that the surgical technology existed and experienced to save you and your girls, the impact of being a privileged member of society, that you are who you are in the city where you are, at the university where you are, so that you received care that might not be universally available, and the difficulty of handling things that are so rare, of knowing how to respond when something is a 1 in a million opportunity, as is sometimes the case with some of the disease outbreaks that you talk about. The thing that really struck me in the prologue of the book, where you tell the story of you and your twins, is another strand of the things that you talk about in the book, which you referenced just a moment ago before I asked you to tell that story, which is this sort of paradox of public health, that when it does its job really well, nothing happens. Right? It has a paradox of invisibility, and that makes it rather difficult to make a case for public health, because people assume that since nothing's going on, nothing must have been done to make nothing going on. You have the lovely phrase that public health turns something into nothing. And so I wondered if part of your impetus in beginning the book, wanting to write the book, was that desire to make the invisible visible for everyone else.
Absolutely. The COVID-19 pandemic really broke public health through into the public's consciousness in a way that is uncommon. It's mercifully rare that we have such disruption for public health events that we are all forced to acknowledge it. And I really wanted to build on that awareness and help people to see, yes, the contact tracing, the guidance, the public communications that you're seeing tied to the pandemic. Those are all functions of public health, and they're happening all the time across a whole range of issues. But you don't usually have reason to appreciate them. And so I really wanted to use the pandemic to advance people's understanding of what else public health does. But I'll note, and Maryn, you probably saw in the book, it's not a COVID book. I think it's too fresh in people's memories, and there's too much out there right now about the pandemic for my taste, for what I wanted to do with the book, which is really to step beyond the pandemic and say, look at all that public health has brought us and what a miracle it is. And here are other ways that we can kind of push the envelope and take it even further, because it is not just a book that is auditory. There are also challenges that I make, and those are all opportunities that I wanted to bring and use the pandemic to put forward.
So I'm glad that you said that the book is not a COVID book. Having read the book, I agree. I feel that there are ways in which the book is sort of haunted by COVID, because COVID presented so many both sort of learnings and challenges about the process of public health. But I do want to hear the audience to hear right up front that we are not going to rehearse the history of COVID in this conversation, because that's not really what the book's about. So thank you for bringing that up first. So as you walk us through some of the sort of learnings and challenges of public health, you immediately, from that discussion of how public health, when it does things well, makes things go away or makes things never happen, you tell the story of one of the biggest successes of modern public health, and that is the just extraordinary, unbelievable eradication of smallpox. And the ways, the technologies that people had to invent, both in terms of the physical technologies of injection and also the sort of logistical technologies of doing vaccination in order to make that possible. Did you get to speak to, have you been able to speak to, in your career, to any of the original smallpox warriors who were actually doing that eradication work on the ground?
Yeah, they're a dwindling number, unfortunately. Smallpox was declared eradicated in 1980, and most of the bulk of the work was done in the 60s and 70s. But I mentioned at the top that I'm a faculty member at the Center for Health Security. It's a point of enormous pride for me and for my colleagues at the Center for Health Security that we were founded by D.A. Henderson, who was the lead eradicator at the World Health Organization. He ran the headquarters program. And upon completing that history-changing event, he returned to Johns Hopkins and took up a position as a dean, held a number of roles across the School of Public Health, and founded the Center for Health Security out of a fear or recognition that there was some preparation being made on the government side for deliberate biological threats. Those are bioattacks, but very little was being done on the civilian side. This was around 1998, 1999. And so he founded the Center for Health Security to advance civilian preparedness. And he was nothing if not prescient at every point in his career, because it was just within 3 years of the center's founding that the anthrax mailings occurred in 2001, which of course was a deliberate use of biological agents to advance terror priorities. And so thankfully, our center, of course, I wasn't there at the time, but our center was in existence to help advise the government in response to that event. So those are the kinds of amazing stories and threads that I really enjoyed when I was writing and researching the book, is seeing how the same characters and the same people who changed the course of history really appear at various points in the arc of public health history. I think that was one of the parts of writing that I most enjoyed.
I was fortunate enough to interview DA a bunch of times relatively early in my career, and I never quite got over the realization that I was speaking to a giant of public health history. It was sort of like being able to interview Jon Snow. But he was always he never rested on his laurels. He was always direct and always kind of ferocious. And you always had the sense that he felt like there was so much more to do. He was really a force.
There's so many times in the last 5 years, really, that my colleagues and I looked at each other and said, I wish DA were here to tell us what to do, because he had so much, not just history and experience, but also perspective. And I think that's a part of leadership that I really admire is people who are able to set a direction and say, we need to go that way. And we're not going to let anything else stop us. And I think that kind of spirit really defines the smallpox eradication campaign and is what enabled it to be successful, really, against all odds.
When you reflect on what the smallpox eradication campaign accomplished, and then you look at some of the other outbreak responses that you recount in the book that have happened since, do you feel like that was a one-off? Would the world ever be able to do anything like that again?
It's true that smallpox is the only human disease we've been able to eradicate, although it is a goal that is set regularly for various pathogens, which is probably a good thing. We should aim as high and be as ambitious as we can. But it was singular in the fact that it was successful and that it pulled together so many stakeholders. Every country in the world had to participate in this. Not just unimaginable in the sense that some people didn't believe eradication could be done. And of course, nothing of the sort had ever been done. And so why did it? Why did it seem plausible that it was doable? And yet every country in the world committed itself to pursuing that goal and chased the virus to every end of the earth. And I do feel like in this moment, not just at the start of the second Trump administration, but really across the challenges and the controversies that defined the pandemic, it doesn't feel like we're in that space right now in public health. There's a lot of divisiveness and erosion, I think, in the public's willingness to really see what public health can bring us. And that's part of what I wanted to do with the book, is really remind people that public health has changed the course of history. It can do so again if we put our backs into it. And when we fail or when we don't give public health all that it deserves, things like the pandemic are the consequences.
I am sure that there are some veterinarians listening, so I just want to be careful to say that though smallpox is, as Caitlin said, the only human disease eradicated, the second disease eradicated from the planet is an animal disease, the cattle disease, rinderpest. So veterinary medicine gets credit for that. I just don't want anyone texting me that I really should be mentioning rinderpest. Good job, veterinarians. Okay, so from talking about smallpox, you go on to talk about less successful public mobilizations, and you tell the really heartbreaking story of what American medicine in particular and public health tried to do about adenovirus and the particular vulnerability that military training, concentrating young people into barracks, putting them through extreme physical stresses, how that was temporarily solved and then left to lapse. And that leads you into a larger discussion of this, something I think we heard a lot about in the past couple of years, which is the regular cycle of panic and neglect that public health, and particularly public health funding, is vulnerable to. Do you want to talk about that, about the history of adenovirus and the problems that the achievement of a vaccine very quickly ran into?
I was an Army epidemiologist. I was a civilian, but I worked for the Army, and it was a basic public health department. But our population was Army service members and their families, and our catchment area was the entire world. So it was a very cool job that I enjoyed immensely, and it was through this role that I encountered the story of the adenovirus vaccine, which is not widely known outside of military circles, because the adenovirus vaccine is only provided to new recruits who are entering boot camp into the military. Now, Maryn, as you described there briefly, boot camp is incredibly stressful from a health perspective. Recruits live in barracks where they're all housed in the same room often. They undergo enormous physical stress through their training. They go on, field-based missions where they're living in rough conditions. It's a very stressful physical environment. And that's exactly the kind of congregate setting where pathogens left to spread. And one of those pathogens that used to routinely take down basic training classes was adenovirus. This is a respiratory virus. It causes flu-like symptoms. It still circulates. It circulates in the general population as well. Many people who are listening have probably had it. But in these very difficult physical conditions, it can cause severe illness. And it was so disruptive to the military that they actually set out to develop a vaccine against adenovirus. And the story of how the adenovirus vaccine was invented is a really fun one, and I hope readers enjoy that part of the book. But I'll fast forward to say that after the adenovirus vaccine was invented, introduced, very successful for decades, it really did the trick in stomping out adenovirus. The DoD forgot. Basically, they forgot why they bothered, because the vaccine was so effective at solving the problem of adenovirus in the barracks that when it came time to work with the pharmaceutical company that was producing the vaccine to upgrade their facilities, kind of do basic maintenance, the DoD refused to put up the money. And despite many discussions and kind of many good efforts on the part of military public health, the vaccine lapsed and it was no longer available to recruits. And just as it had decades before, this immediately led to a serious resurgence in adenovirus. And it was not just a matter of disrupting readiness, of interrupting training cycles because of all of these people falling ill. There was actually 8 young people who died of adenovirus infection. They were all 18, 20 years old, had just begun their military careers, and they died of an infection that had been preventable for decades and had only recently kind of been allowed to come back. And this story of identifying a problem because it is so harrowing, solving it, and then the peace that is created through that solution allows people to forget and to really relax in a way that they let their guard down. They don't make sure the vaccine is in stock. They don't make sure that people remember what it's like to have a child with measles or smallpox, clean water, to really appreciate all that they're benefiting from. And so, of course, the funding dries up, the momentum stalls, and the old problems resurge. And this cycle of panic and neglect defines so much of what we see in public health. I wanted to make sure to put it right at the top of the book. And unfortunately, we're seeing it right now with COVID-19, I'm afraid. And so it's not just a story of historical interest. I think it really speaks and offers a warning to contemporary times.
So I'm going to remind folks who are watching, thank you all, I see there are lots of you, that you can put your questions for Dr. Rivers into the comment boxes wherever you are, and we will see them. I do see a couple of questions already. I am going to get to them soon, but we would love to hear from more of you. We have more than half an hour to go. We have loads of time to ask questions. So, Caitlin, the story of adenovirus, I think, reminds us that something that is an old technology, vaccines. I mean, there are new forms of vaccines all the time, but vaccination itself is an old technology, are so important even today. And in the next story that you tell in the book, which is a coronavirus story, but not about COVID, you make the point that all the other sort of low-tech methods of public health are so important, of contact tracing, of forcing people into isolation, of recording who gets sick when and where. And that's the story of SARS. I covered SARS as a reporter. I vividly remember some of the days that you recount in this story. But SARS, I think, has kind of vanished from a lot of people's memory, not just because it was 20 years ago, but because it was eclipsed by this later occurring coronavirus. So maybe fill us in for a bit about why you thought it was important to tell that outbreak story.
The story of the SARS pandemic in 2003, I think, is one crystal clear example of how epidemiologists and public health professionals pulled us back from the edge. This was a very scary outbreak. It was an ancestor of SARS-CoV-2, but there were a couple key differences. Like SARS-CoV-2, the original SARS began in China and quickly spread around the world, but it was a lot more deadly as a virus. Around 8% of people who were infected died. And unlike COVID, which can spread even before you have symptoms and certainly early in the symptomatic period, people with SARS were most infectious late in the course of illness, like when they were in the hospital. And so not only was this a very deadly virus, but it was spreading very efficiently in hospitals and infecting other patients who were there for other reasons, doctors, nurses. It reached Canada and became so dangerous in parts, certain hospitals within the Canadian health system, that they were closed to other patients, and was just a crystal clear example of what a pandemic looks like when it is beginning to unfurl. Through the traditional strategies that epidemiologists have used really since the time of John Snow, of contact tracing by identifying people who had been exposed, isolation and quarantine, of really pulling them out of circulation and making sure the virus doesn't have a chance to spread further. Those core strategies were used, once again, kind of echoing the language I used for smallpox earlier in our discussion, were used to chase SARS through every corner of the earth, cut off every single chain of transmission and pull it back. And what I find particularly remarkable is there was no vaccine. Diagnostic testing was in its infancy, and we didn't have any of the kind of convenient communication and identification technologies that we have now that have accelerated the work of contact tracing. And so it's really a remarkable feat of shoe leather epidemiology that the SARS pandemic was not allowed to spread out of control, and that it was brought under control through amazing efforts.
In just a few months. I mean, those first cases were in the spring of 2003, and I think it was by July that the WHO was able to say that outbreak was over.
It was exactly the kind of situation where I think the general public, maybe even then, and certainly now, don't appreciate what it means to turn something into nothing. That pandemic was bad enough as it was, and it could have been a whole hell of a lot worse. And so I think it's incredibly special and memorable and instructive that it was brought under control.
So this is a really good time to ask one of the questions that's come in from watchers. Ananya Dash asks that you must have come across many types of outbreaks as you were researching the book and thinking about what to put in it. So how did you choose which stories to tell?
This was a place where I really had to grow as a writer. I've always loved writing and storytelling, but I'm a scientist. I'm a professor of epidemiology. And so I had to be very thoughtful from a storytelling perspective of which outbreaks really illustrated the lesson. That's one of the things I'm proud of, and that I hope really comes through in the book, is they aren't just compelling stories, although I hope that is true, but they also have kind of a moral or a parable to them that tells a lesson about the kinds of forces that shape public health. And so I tried to be very thoughtful about selecting stories that could help me to do that and to reach a little deeper.
So I think now we actually have to talk about COVID because we've been talking about storytelling, which is effectively a form of communication. And in the middle of the book, where you begin to turn to more recent history, you say some pretty pointed things about the responsibility of public health to communicate and how public health doesn't always get that right. And to provide a contrast, you tell a really marvelous story that I'd never heard about how weather forecasting learned to speak directly to the public. So tell us about that.
Yeah, so I do find the history of weather forecasting instructive as it relates to epidemiology across all kinds of dimensions. And I shared a little bit about my history with the Center for Forecasting and Outbreak Analytics, which is meant to be something like a national weather service, but for infectious disease outbreaks. Well, another lesson that I've learned from my weather colleagues is how communication has evolved over the years. And I tell a story in the book of how in the early 20th century, it was against the rules, actually, for meteorologists to warn of tornadoes. So they could do things like warn of severe storms and high winds, but it was forbidden. It was taboo to say the word tornado. And the consequences of this were quite predictable in that people were not adequately warned of tornadoes that would come and devastate their towns, their communities, take lives. And the justifications that meteorological scientists gave for why tornado was forbidden were so resonant to me for the justification that I sometimes hear from my public health colleagues about keeping information from the public. Meteorologists said things like, that the danger of taking shelter in damp basements would have its own health hazards, and we wouldn't want to risk that. There was concern over stoppage of businesses and how tornado warnings would affect the economy. There was concerns over false alarms and crying wolf. And there was even someone who said that getting hit by a tornado is it's so deadly, you just die. Like, what's the point of a warning when it is just unavoidable death and destruction? And those sometimes make me chuckle a little bit because they are so far away from how weather scientists think about communicating with the public now. The science and the community has really evolved such that inspiring people to take action by equipping them with information about what's coming is absolutely central to how meteorologists think about their jobs. They now, even in the last, say, 20 years, weather warnings used to say things like barometric pressure is falling. Nobody knows what that means. I don't know what barometric pressure is. But now storm warnings say things like small trees will be uprooted, flying debris will break windows. And they made that transition from saying nothing to saying something, but it was a little bit hard to parse, to being very clear, was done on purpose because the weather community really recognizes that it's their responsibility. That the goal of their work is to protect lives, livelihoods, and property. And I worry in public health, and particularly in outbreak science, we're a little bit more on the taboo side, where there is some reluctance to really name our fears, name things that could be coming in terms of outbreaks, and really just thinking more about preventing panic. I hear that phrase a lot, preventing panic, than about equipping people with the information they need to keep themselves and their families safe.
You make such a clear contrast in the book between what weather forecasting learned to do and what, for the most part, public health didn't manage in the first 6 to 9 months of COVID. That public officials were attempting either to keep the public from being too frightened, or were keeping them from doing things that they thought would be the wrong thing. You have such a clear parsing of the fight over what to say about masks, which of course caused so much difficulty in the ensuing years and continues to still.
Yeah, I think it's really a shame because I do think my public health colleagues have the best interests of the public and outbreak control at heart. But I just want to encourage some re-strategizing of how best to achieve that. So in the case with masks, for example, there was a lot of public communication that not only do you not need a mask, not only is it not helpful, you actively should not wear one. Do not wear a mask. And the science around mask wearing was young. There are some kind of uncertainties that were pervasive in those early days. But what was actually happening, the kind of unstated third variable, was that there weren't enough masks. And the people who really needed them, most of all, were healthcare workers, of course, because they were the ones caring for people who were infectious and ill. But instead of really laying that out for the public and saying, like, masks are helpful in some contexts if you have one already, or if you want to make one, that's fine. But please be mindful of the fact that healthcare workers really need. If they had said that, then it would have been a completely different story than what they actually said, which is that don't wear a mask, don't wear a mask, don't wear a mask. And I think that that there was a lot of trust that was lost in that conversation. And I also want to highlight that when these complexities became clear and when the public was told directly, please preserve masks for healthcare workers, people did it. People listened, people understood, people participated in this kind of prioritization. And so we really should have started with that. And I hope that's a lesson we can take forward for the next crisis.
So we're getting some great questions from people, and I promise that I'm going to ask them in a couple of minutes, but there's a few other questions that I want to ask first. So the question of how should public health communicate, I think is very related to another issue that you examine in the book, which is the question of how much public health can be sort of its own thing, just making health recommendations, and how much it needs to sort of step into the political arena. And you make the comparison to the National Institutes of Health, which has a pretty chummy relationship with Congress and whose budget probably reflects that. But you also evoke this continuing problem of invisibility, that public health doesn't have sort of celebrity diseases in the way that NIH does. So when you say that public health should be more political, which I think is part of the communication issue that you're talking about, what is it that you have in mind?
There's a big refrain that I've been hearing since the pandemic, but this discussion has been ongoing for many, many years, that we need to get politics out of public health. And when people say that, I think what they mean is we need to prevent political interference in the development of guidance, for example. There was a point during the first year of the pandemic when political leadership under the first Trump administration really inserted themselves into the discussion about school reopening and had a like a banner or like a standout thing on the CDC website listing reasons why school districts should keep schools open. And that was a negative example, in my opinion, of politics and public health, where political leadership really put their finger on the scale when it came to public health guidance. But when I hear the phrase get politics out of public health, I worry that the larger message is that public health should not be engaged with politics at all. And I know there's some fuzziness there, but the argument that I make in the book is there is nothing we can do in public health that is as consequential as smallpox eradication or PEPFAR, which is the main story I tell in that chapter in the book, a program that has saved tens of millions of lives by providing medication and other treatment options for people with HIV and AIDS. There's nothing we can do on that scale without partnering with our political colleagues. They're the ones that grant authorities, they have the power of the purse. And so we need to be thinking of ways that we can partner with them to advance our work. And I just don't want us to lose sight of that key fact that there's so much power in what political leaders are in charge of, that we really have a responsibility for ourselves, for our profession, and for our communities to build those relationships and make those advances where possible.
So for those who are not in public health, I just want to unpack that acronym that Caitlin just used of PEPFAR, which is one of the largest public health global projects that the United States has ever undertaken, and led the world in doing this in addressing HIV/AIDS, particularly in Africa. It was a creation of one of the President Bushes. It was a Republican creation. It was not something that was done by one side of the aisle, and it has saved millions and millions of lives around the world. It really underlines that public health, though it's political, is not partisan. But having opened the door now to the question of politics, I think everyone has been waiting to hear us talk about what's going on in the United States with public health and biomedical science in the past 10 days since the second Trump administration began. What is it you would like to say about what we've been seeing in terms of program suspension, funding suspension, what the future looks like?
There are really more developments than I can even keep track of, but a few that stand out to me as particularly consequential are the halt on foreign aid, foreign assistance. This was a directive that basically prevents, in the short term, prevents the U.S. government from distributing aid, even that which it had long been committed to, like providing HIV medication under PEPFAR. I'll be honest, I don't know if it's currently frozen or unfrozen because it seems to change minute by minute. But the fact that that was even a step that was taken is enormously troublesome and dangerous. It would absolutely lead to lives lost if it was still frozen. Another one I would like to highlight is a similar freezing or halting of federal grant funding. The vast majority of scientists like myself who work at universities do our work thanks to federal money, and so the cessation of that, the stopping of flowing of that money is scary and consequential, and would definitely impede our ability to do our work. I think the last thing I really have my eye on is the confirmation hearings for Trump's nominees for key health posts. Robert F. Kennedy Jr.'s first hearing was today. He has more upcoming, but he's been a longtime leader in the anti-vax community, and I do absolutely worry about what his leadership would mean for vaccine coverage and for a whole host of public health issues. Similarly, there's a number of other public health leaders who have been nominated and are waiting confirmation that have track records that I don't always agree with, and that's not necessarily. I don't want to give the impression that disagreements are unpalatable in some way, because there's always room in public health to reach across that aisle. But I really hope that those confirmation hearings are used to explore the intentions of the people taking those offices, because it is such an important time for public health. We really need to make sure we have strong and committed leaders in those posts.
I think this is the point at which we should sort of try to look to the future, not just the future of these confirmation hearings and what's in store for at least the first 2 years of the Trump administration, but what is the future in terms of outbreaks and outbreak science? Toward the end of the book, you start to talk about projects that I think we heard about a lot just around the beginning of COVID, which are sort of the viral discovery and prediction projects that attempt to look into the animal kingdom and find points of spillover in hopes that they can be early warnings for what might be coming our way next. You sound a little skeptical of those, and I wonder what you think we should be doing to try to detect what the next threats are.
I would really encourage political leaders to not fall prey to panic and neglect. I think that is the number one thing we can do to secure our future against public health threats. I note that in the House budget, last budget cycle, which did not get passed into law, but was put forward by the House, public health funding was cut by something like 40%. There were entire centers at CDC that were just decimated. And it's that kind of threat to basic public health resourcing that I think is most consequential. So looking to the future, I would really encourage a more appreciation for, again, all that public health does for us. Now, Maryn, you kind of have noted throughout the interview about the balance of new technologies and how those have played an important role in shaping public health. I am a little bit skeptical of our ability to not just find, which I think is possible through sequencing, for example, but intervene on viruses that have not yet found the human population. I think that's a tall order. And that's part of why I spend a good chunk of the book really highlighting the importance of basic public health interventions like contact tracing, isolation, and quarantine. Those are always going to be our frontline tools for outbreak response. And so as we're doing things like inventing the American Pandemic Preparedness Plan, which is something that the Biden administration put forward, often there is a lot of emphasis on technological tools, our ability to develop vaccines faster, our ability to find viruses when they're still circulating in animals, kind of all of these technological advances. And I just don't want, in those conversations, we should do all that, but I don't want us to lose sight of the fact that it is basic public health that is going to be there from day 0 to 100.
This is probably a good time to talk a little bit more about the work that you did at the CDC, and I think that you continue to do in association with them. What does having a national weather service for outbreaks really mean? When you think of looking forward to where the next threats are coming, how is that reflected in your own life, your professional life?
Yeah, I had the good fortune of helping to start the Center for Forecasting and Outbreak Analytics at CDC, and I had been involved with advocating for this capability for a very long time. The reason why it's so important that we have such a center is that modeling, and by that I mean things like forecasting, asking what if questions, what if we build more hospital beds, what if we're able to roll out a vaccine 20 days earlier, these kinds of questions are actually modeling based. And prior to the advent of CFA, it was really academics in academia like myself, professors, who were called upon to do these analyses, but they did so often without any funding, without any formal connections to the government, without sometimes public health practice experience. And so it was really not a fit for purpose capability. And so what we wanted to do with CFA is really build that in-house and really build the capability to support decision makers like the CDC director, like state public health departments, in making consequential decisions about outbreak control using models and analytics and tools that were purpose-built to support them.
So I think we have to raise the issue that seems to insert itself into every question these days, and that one of our listeners is asking, which is, what is the role of AI going to be in this? Is this something that actually has a role in outbreak forecasting?
Maybe, yeah, I think it very well might. I see, maybe it's just my kind of vantage point, but I see a lot more basic purposes for AI that I'm excited about. One is generating and synthesizing information. You can tell through the course of our conversation that I'm very passionate about making sure that the public has the information it needs to make decisions, for example. Well, writing documents like press releases and talking points and situation reports, it's very time consuming. Public health departments do not have a lot of time to spare. And so I can really see a use where, for example, details about the outbreak are uploaded to AI and documents fit for 10 different purposes are written automatically. I think something like that, though basic, could be enormously helpful. Now, it may also be the case that there's a use for AI in constructing better models and kind of the more far future stuff. And I'm sure people are working on that. But again, kind of building on our earlier points of discussion, I don't want us to lose sight of the work of basic public health. And I don't want us to stop thinking about how we can support those activities.
So a consistent theme in the book is the necessity of communication and of communicating clearly. You make up the point late in the text that an essential function of public health is persuasion, that it can't successfully command people to do things, that it needs to do as much listening as it does ordering. And as a science communicator myself and a journalist, of course, I 1000% support this, but I wonder what you think about the very contested, let's say, communication environment we find ourselves in right now, which really was on display in the last couple of years of COVID. How do you see public health finding its way through very basically contested facts and accusations of fake news? How can it chart its path to communicating usefully with the public?
It's so true that we're facing a really fragmented communication environment. And it used to be that the CDC, for example, was the canonical source of public health information. And if you wanted to know what was happening, you tuned in. But these days, there's a lot more nodes in the network and a lot more layers. And that's part of the reason that I participate in public communication. I have a Substack, Force of Infection, where I write every week. And I am active on social media, and none of that is part of my job as a professor. It's just work that I think is important and that I have something for a knack for. And I think that there are probably a lot of other professors like me who are looking for an excuse or a little boost to kind of get into public communication. And if you're waiting for that sign, here it is. I think that we all need to, we who are experts or otherwise influential in our roles, need to really step into that responsibility and be providers or arbiters of good communication.
So I think we are coming up toward the end of the hour. This has been fantastic. Is there a final message that you want to leave this audience with?
There is a lot going on in public health. It's a very tumultuous time as we face there's a pause of frozenness. I keep struggling with that word, but there's a pause on federal public health communications. There's problems with grants. I really hope and think that the book can help listeners and readers decode what is happening, what that means, and the kinds of forces, how they shape public health and how that changes outcomes. And so I would kind of offer that as something of a balm or a salve through these difficult times. I think the book can maybe help people make sense of it all.
And it's a fantastic book. Thank you for coming to talk about it.
Thank you.
So that's it for this edition, the first of the spring, of the Health Storytelling Author Q&A series. Please consider following Caitlin on the social media that she just mentioned. She uses the handle CMY Eaton on Twitter or X and Blue Sky. And after you have found her there and on her Substack, as she said, it's titled Force of Infection. It's fantastic. Please go buy her book, which is available at Penguin Random House, her publisher, and at Amazon, of course. And if you are trying to use Amazon less, we entirely support that you look for the book at bookshop.org. It's sort of the anti-Amazon. It's a platform that funnels orders to independent bookstores who will send the book to you. Join us next month, February 26th, to hear from Dr. Adam Ratner about booster shots, the urgent lessons of measles, and and the uncertain future of children's health. I think, given some of the trends that Caitlin has talked about tonight, that book is going to be even more important next month than it is right now. You can visit our RSVP page to sign up in advance for that live stream and our later ones with Carl Zimmer and Jack Jarrod. We hope you'll join us then. Until those, I'm Maryn McKenna. On behalf of the Center for the Study of Human Health at Emory, the Georgia Center for the Book, Emory's Center for Public Scholarship and Engagement, and its Ideas Festival, and the Atlanta Science Festival, and from me, thank you for watching.